Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello, I am Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast where we share the most up-to-date education for healthcare professionals. So welcome to our podcast on holistic approaches in palliative care. And joining us for this discussion is Melissa Doris. Melissa, thank you so much for joining us today.
Thank you. I'm happy to be here.
Can you share just a little bit about your background in palliative care and what really made you pursue this area?
So I actually started in hospice care in 2000 as an aide. And then when I went to nursing school and graduated, I did work in acute care. And then because I had done hospice before, I wanted to do that also as a RN. So I started it as an RN in hospice in 2005. So this will mark my 20th year.
Wow.
And I've gotten a really great opportunity to do hospice, inpatient and outpatient, as well as palliative care, outpatient, and inpatient consulting as well.
Yeah. You have so much knowledge. 25 years, is that what you just said? Oh
Yeah.
my goodness. Well, first of all, congratulations. 25 years is
Thank,
a long time, but your dedication to our profession and to your patients, I just want to commend you for that.
thank
Um,
you.
wow. So through this episode, I really want to explore the holistic practices in palliative care, but trying to focus on the physical, the emotional, and the spiritual well-being of the patient. So really, the patient as a whole. And really, my goal is going to be hopefully we can just provide healthcare professionals with some insights and strategies they can use to enhance the quality of life for their patients who are receiving care.
Hmm.
Now, I have seen that there's been growth within hospice and palliative care in the US, that especially over the last decade, where the number of patients that are looking for treatment in this area has increased by almost 60%. Are you seeing this trend? And do you think it reflects is there a growing recognition of what can be offered and maybe an understanding of what palliative care and hospice is?
Yes, absolutely. So, I mean, hospice was introduced into the United States back in the 70s,
Yeah.
but it didn't become part of the Medicare benefit until the 80s.
Oh, wow.
Um, and so I have seen an uptick, and I think a definite positive to that has been, now we have the internet,
Hmm.
social media. Um, we've had a president who received hospice care, a former president, for over a year, and that has received a lot of recognition. And also, they are starting to offer some reimbursement for palliative care through the Medicare benefit, which we didn't see that in the last 10 or 20 years.
Yeah.
Um, but there's still a whole lot more education that needs to be done.
Hmm.
Patients are electing hospice still in the last weeks to days of their life, when palliative care is most beneficial 6 months or more.
Wow. Yes.
Mhm.
I did see when I was looking, through things for this podcast that actually a lot of the patients that are in these types of programs are starting to be Medicaid, Medicare. Is it Medicare that falls under? They're starting that they are underneath Medicare versus private insurance.
Right. So we are seeing, I mean, in the last few years, I have seen an uptick in younger patients.
Mm.
Um, so Yeah, it depends on the state, but there are still some states that Medicaid does not cover hospice care. Um, and because the reimbursement for palliative care is so low, that you don't find a lot of outpatient palliative care options. Some home health agencies are partnering with larger commercial insurance companies to offer some palliative care in the community. And there's still many hospital systems that don't have a palliative care component,
Mhm.
especially in the smaller hospital systems or rural areas. So that is definitely a disadvantage if you don't live in a big urban or metropolitan area. Um, there are still commercial insurance plans that don't cover hospice, or they have a very few hospice agencies that they contract with. So that makes it a little harder for those patients to access the care.
And then when you were talking, I was thinking, the rural versus those that are in the city. Um,
Hmm.
it's almost, if we have the desert area where it comes to healthcare, then you're probably not gonna find what you need for palliative care, hospice care either.
Yeah, I mean, there is a growth, and again, it's all state specific what their
Mhm.
rules and regulations are on opening a hospice. So there are hospices that cover rural areas, but it makes it a little bit more difficult as far as depending on how far the patient is from the office, what the response time is of the hospice if they need something versus a routine visit. Um,
Right.
and
Yeah.
that can certainly impact the care.
Yeah. Let's back up just a little bit. Um, can you help? What is holistic palliative care, and how does that differ from traditional palliative care approaches that are used?
So, if you think about just traditional palliative care, for instance, if you had a cancer treatment center or an oncology clinic, I just use cancer as because it's the easiest to decipher.
Hmm.
They may have a nurse that talks about or helps with palliative care. But when you're looking at a holistic approach, when we have to look at the whole patient, um, you must have a social worker and a chaplain so that we can focus on the physical needs of the patient, their emotional needs, and their spiritual needs. Um, because all of those different factors can impact the palliation of their symptoms.
Right.
And
It
so
it seems
that's,
like that's what you're taught in nursing school too. We're taught to look at the patient as a whole.
hmm.
Um, and so, but when we got out of nursing school, and you probably have seen this too, 25 years. I just love that so much. I'm getting close to that. I'm not quite there yet, but I'm getting
Right.
close. But when we came out of school, I didn't really see where we treated a patient as a whole. Um, it was this is their diagnosis or their disease process, and this is their
Hmm.
treatment. And you didn't, and still even today in some areas of healthcare, I still don't see where we're looking at the patient as a whole person, a whole being. Um, and so just hearing like this holistic palliative care versus the traditional, it just takes me back to that. We should have always been looking at patients, regardless of where they are in their healthcare um, continuum, from healthy
Right.
to sick to being born to dying. We should we not have already been doing this?
Yeah, I think you see that a lot in an acute care setting.
Hmm.
I've worked as a nurse at the bedside in acute care, and we're so focused on whatever reason they came into the hospital. Um, we don't we don't know what happens to them when they leave. And then you see patients that keep returning to the hospital. Um, and is it just a physical need, or are they really needing help
Hmm.
in their spiritual journey, or are they having psychosocial issues occurring that maybe we failed to notice, or we just didn't have the time to address those issues? And I think that a lot of times that's why patients frequently return to
Hmm.
the hospital.
They don't have all of their needs met, and they
No.
don't know how to meet their needs, and they probably don't know what their needs are. They just know they need something.
Right.
Um, Now, is there a difference between the term palliative care and hospice, or are they intertwined? Because I know when I think of hospice, I think of, I think of the clinic down the road that has, hospice on it and, that's the name of
Mhm.
it and, oh, we're gonna call in hospice. But is there a difference between those terms or are they intertwined?
So I think sometimes we like to intertwine them, but there is some separation. So definitely in hospice, we palliate symptoms. So that I, but in palliative care, when you're talking about palliative care, patients are still pursuing curative treatments.
Mhm.
And so palliative care is meant to help with whatever symptoms they're experiencing. And if it is a true palliative care program, they also are looking at their psychosocial needs and their spiritual needs. So when I like to explain what the difference is, I kind of talk about hospice as being a bridge.
Okay.
So they can start in palliative care and then if they make a decision to forego any curative treatments or if those curative treatments are no longer effective and they just want to focus on their comfort and their symptom management, then they can cross over to hospice where it's still holistic. We still have an interdisciplinary team with social worker and spiritual care. But now we're no longer focusing on treatment. We're
Mhm.
just focusing on palliating their symptoms. And so I hear it talked about synonymously, but there is a significant difference.
Now, when you were talking about insurance earlier, one of
Hmm.
the things that I hear when people are debating on, am I going to call and set up hospice? They are debating on, do I want to give up the treatments to try, the curative treatments?
Hmm.
So when it goes to insurance, are there insurances that will pay for that palliative care while they're seeking curative treatments?
So with Medicare, because hospice bills their Medicare Part A, which is also their hospital coverage,
Hmm.
for whatever diagnosis they were brought onto hospice for, they won't dual pay. So the patient has to understand that once they choose hospice, all of those curative type treatments are going to stop. Um, when they're on palliative care, they can still continue their treatments. Medicaid varies from state to state, and I can't even
Right.
say that I would begin to know what that would entail. Um, for commercial insurances, it really depends on their plan. Um, and how it's carved out, what that benefit looks like. So again, that would be very individual based
Hmm.
on their healthcare plan. The only caveat to that would be pediatrics. Um, Pediatric hospice or pediatric palliative care is on a whole different level where they may cover a lot more than they would for an adult.
Right. And those are hard decisions that to make too. Um,
Absolutely.
do you think that maybe that's why so many don't actually come to hospice until weeks before um, their death?
I believe that, um, and I also believe that there are still a lot of physicians and providers that need continued education. Um, I mean, if I was given a diagnosis, I would wanna weigh all of my options,
Right. Yes.
and I would want all of the information so I could make an informed decision,
Hmm.
but I think that there's times where patients are offered options and they're told this could extend your life 5 years or this could extend your life for 2 or 3 more years, but they don't really understand the gravity of the treatment and what that is gonna do to their body,
Right.
what that's gonna do to them, not just physically, but emotionally, financially,
Hmm.
um, and spiritually, depending on where they are in their spiritual journey.
Right.
Um, so I think that all of those factors combined. And there's still a lot of misconceptions that hospice means death,
Yeah.
um, and that the minute you choose hospice, that you've given up, and that you're going to die. And although we've made great strides, speaking about death and dying is still a pink elephant in the room that nobody
Absolutely.
wants to talk about.
Yes, it really is. But I was also thinking when you were talking about needing education, also needing education by, what you just pointed out, there's a difference between palliative care and hospice.
Mhm.
And if you receive this diagnosis, then we should be able to look at here are the treatment options we have, but we also want to offer you palliative care to go along with it, not because we're saying you're going to, to die from this diagnosis,
Right,
but to help you through the treatments and the symptom management and the way that your life is about to change potentially
right,
through this time. So, because I didn't realize that there was a difference between palliative care offerings and what hospice also offered.
right. So working with palliative care in an inpatient setting, um, we had a team, we had a social worker and a chaplain, as well as physician and nurse practitioners. And so we could palliate their symptoms, whatever symptoms they were having, but also help them work through whatever, psychosocial issues that they were
Right.
having, um, and offer them all the information that they needed
Hmm.
so that they could make an informed decision, not necessarily about their treatment plan, because that's not what our intent is, but just to offer them options and let them know that it's okay, that it's not them giving up
Right.
if treatments are no longer effective. That, I mean, unfortunately, we
Hmm.
can't always beat the disease, and it's not a reflection of our mental strength or our physical strength.
Right.
Sometimes we just can't.
Absolutely. So when I was preparing to meet with you today, I would looked at some statistics around palliative care, and I really did search palliative care. And
Hmm.
what I found was that there was a 40% improvement in patient reported quality of life and a 30% reduction in symptom burden.
Yes,
I just
I
think
believe that.
if we understand how helpful this is and we're able to help our parents, our patients, and it might be our
Right,
parents, you never know,
right,
but help our patients understand that these approaches are worth it, that we're looking at you as the whole person and not just the disease process or the symptom progression. Those are some pretty good statistics and a reason why we should be offering and making sure they understand what palliative care is.
right.
Now, what role does pain management play when we're looking at it from that holistic point of view?
I don't have the exact statistic, but most people don't even seek medical care until they're having pain or
Mhm,
discomfort.
mhm.
And there are times when by the time they start seeking medical treatment, their disease is already very progressive. Um, but if you are in constant pain, not only does it affect your physical well being, it also affects you emotionally and spiritually. I'm not a chaplain or have
Yeah,
any education or training, but I have seen patients really suffer with their spiritual pain. It is a very real thing. Um, Depending on what their cultural background or their belief system is, maybe at one time they believed in God, but now they haven't been living their best life. They feel that this pain is they need to feel pain in order to pay for whatever
mhm.
wrongs that they've done in their life. And I don't know about you, but if I'm hurting, I'm not sleeping well,
No.
I'm not able to eat, um, I might be irritable, which then affects personal relationships. Um, and then again, all of those things compounded can certainly impact your quality of life. A lot of people that are going through treatment still want to continue to work. But if you're in severe pain, you're not able to do that. And then that takes away from their personal identity,
Yeah,
their independence, and all of those things. So it does play a significant role in their overall well being and quality of life.
absolutely. And when I was looking, I saw that for hospice, it says it's for hospice, but I feel like this probably would be true for palliative care too. But it says pain
Hmm.
management is a cornerstone because that
Yes.
focus is on quality of life, on, comfort during that journey, whether this is the end of your life journey,
Mhm.
but it's a cornerstone. What would you say?
Yes, and what I've seen, and is most especially in an acute care setting, we live in a very difficult time right now as far as
Hmm.
the opioid epidemic going on in our country, and therefore there's a lot of fear with physicians or providers on um, prescribing adequate pain medication for obvious reasons. So
Right.
when palliative care comes in, I know we did this in the hospital when I did inpatient palliative care. Our physicians were well trained um, at doing very thorough pain assessments and deciphering what type of pain that the patient was experiencing so that they could prescribe them the correct medication.
Hmm.
Um, you know, there's some pain where an opioid is not effective.
Right.
So no matter how much opioid you give them, it's not going to take care of that specific type of pain. Um, and so that is where I feel it's the most beneficial um, when we're talk about the cornerstone, because that is ideally what we're trying to do. Is we may not be able to bring their pain level down to zero, but
Right.
we want to bring it down to a level that's tolerable so that they have better quality of life and can visit with their family or can go and
Hmm.
do the things that they want to continue doing that bring them joy.
Absolutely. Would you say when you were talking about, that fear of prescribing, but also I see the fear of patients taking
Yes.
medication as well. Um, if we are in the palliative care, or even if we're in hospice, I don't know if you want to differentiate between the two in this
Hmm.
question, but should we be worried about addiction uh, while we're trying to treat them at this point in their life?
That is a huge myth. And it does become a barrier, both in palliative and hospice care.
Mm.
Um, you know, the gold standard tends to be morphine, and morphine has a very negative reputation. Um, And so that's part of what we do, at least from the nursing
Hmm.
side, is educating the family and the patient. We're not worried about addiction. When acute pain or chronic pain is being treated appropriately,
Yeah.
um, addiction is a psychological need for that drug. But when we are treating acute or chronic pain, the chances of addiction are very minimal, and it's not even something that we're thinking about because our focus is starting them on the lowest dose possible so that we
Hmm.
have room to titrate it if needed. But we also want them to be as awake and alert as possible, although there are times when that isn't possible, especially if they're adjusting. Um, And so we just do a lot of education about that.
Hmm.
We're starting at a low dose and we're not going to increase it unless it's needed.
Right.
Um, and if that medication isn't effective, there are other choices that we have to ensure that they get the best pain management
Right.
possible.
When you were started talking about morphine, I also know that
Mhm.
there is some, I don't know that I would necessarily call them myths. I don't know how you would want to address it, but for example, my grandmother, she had leukemia, and she was in a lot of pain. She was at the end of her journey with leukemia. And my brother and I are both being, in healthcare and healthcare professionals. We made the decision to give her morphine,
Mhm.
knowing that she was gonna pass away, and she
Right.
knew that as well, but we made the decision to go ahead, and she was in a lot of pain, she agreed to take it, but she knew what was gonna happen, and we also knew. But I hear a lot of people also referring to, "Well, they gave my parent morphine, and then they died, and so they
Mhm.
gave them too much," and what are your thoughts behind that? Like, the education that needs to be given,
Mhm.
our goal is not to you know, is not death and given the
Right.
morphine. Our goal
Right.
is to relieve your pain, and if this happens, this happens.
Hmm.
Uh,
So a lot, I mean, I hear that all the time.
yeah,
Um, and also from nurses that are administering the medication. They don't want
yeah,
to give it because they're afraid that dose is going to end that person's life. The truth is, with morphine, you have to give very large amounts in order to suppress the respiratory effort. And we use morphine for pain. We can use it for air hunger.
yeah,
We can use it for extreme anxiety to kind of help them to relax. Um, if you have a patient that has been in constant pain or high levels of pain for a very long time, a lot of times what happens is we get their pain managed and they're actually able to relax.
yeah.
And then that kind of can allow them to enter into the dying process. But the morphine is not what caused their death. We start with a dose as low as 5 milligrams, which might be equivalent to a Norco, which people are really comfortable taking Percocet or taking
Yeah.
Lortabs or taking Norco. Um, Morphine is those are much more potent or much stronger, and that's why we start at such a small dose. Um, and so it's just that constant reassurance. Um, if they don't need it, we're not going to give it. We're only going to give it, if they really need it. And so that is a constant education and reassurance that that small dose of morphine didn't cause their death. They
Mhm.
were already their disease is what caused their death.
Right.
No matter what we tried to do, we weren't going to be able to prevent that.
We were just trying to help them transition more comfortably.
Exactly.
Yeah, which is how, me and my brother were explaining it, to our family as well,
Hmm.
is that this is just to help her to be comfortable through this night.
Right.
Um, so I know we talked about morphine and other pain management with medications, but what about non-pharmacological methods for helping with managing pain?
I mean, I educate nurses all the time that, you know, we can't just go straight to medication. Medication can be helpful, but I always like to ask questions, talk to the patient. When you're feeling stressed or you're feeling uncomfortable, what helps you to relax? What do you do for you? And so some of those non pharmacological interventions could be guided imagery, meditation. I've seen music therapy be very effective. Um, it's actually the most beautiful thing to watch is a music therapist come
Yeah.
in and play music. Um, you can do aromatherapy for some people. For some people, aromatherapy can actually exacerbate their symptoms if they're having nausea, or if they're really in tune to some smells. But it can be effective, especially in patients with Alzheimer's or dementia diagnoses. They get agitated,
Hmm.
and you can introduce an aroma maybe that was familiar to them, aftershave or a certain type of lotion, something that kind of brings them back to a time that they can recall. So I've seen that be very effective. Massage therapy, um, depending on where that pain is, can help them to relax. I know if we've ever experienced stubbing our toe or some acute pain, every muscle tenses up because we're, trying to address that one area. So all of those complementary therapies can be very beneficial if that's something that the patient is receptive to and has
Hmm.
responded positively to in the past. Repositioning,
I was gonna
um,
say that's my
yeah,
that's my start. I like to start with repositioning and then go from there.
yes. Hmm.
Um, yeah, keep going. You're
Um, yeah, repositioning, and sometimes, if they're able or we have a safe way to get them out of bed,
Mhm.
into a chair, or um, maybe they need to get out of the four-walled room that they're in, um, so they can feel the sun on their face or they can feel the fresh air. Um, So I think that there's a lot of different ways that we can help alleviate some of that pain, but we have to talk to the patient and ask them if that's something that they would like to do.
Right, because it's I like how you said talk to the patient, because to me that
Mhm.
allowing empowering, I guess is more the right word that I wanna say is,
Yes.
empowering the patients to really participate in their own comfort. What does bring you relief? What doesn't bring you relief? And
Mhm.
helping them to participate in it, because as that nurse, you're not always gonna be in the room with them, or available to them, since this type of care is usually in their home,
Mhm.
versus, in a hospital setting. I know we do have some where it's more of like kind of a nursing home rehab type setting, but a lot of
Mhm.
palliative care and hospice takes place in the home. Um, and so, helping them to be able to participate, and the family members as well, being able to participate.
Absolutely. And whoever they deem their family to be.
Right.
Um,
I have a lot of
so
family friends that are family.
yes,
um,
absolutely.
Yes, who are, always standing by you, so I completely understand. And that's I wanna ask you about that too, since you brought that up. In a hospital, it's usually family. It has to be
Mhm.
family, but, is there more freedom in palliative care and hospice care for, uh, friends who are family to participate in the care with the patient?
Absolutely. So really the only time if it has to be a family is when we're talking about consent forms or legal
Right.
documents. Who has the legal authority to sign for that patient if they're unable to sign for themselves. But when it comes to their home, we are a guest. We're a guest in their home. And, um, you know, in any nursing environment, you always, if there's someone else in the room, you always ask, is it okay if I speak to you about what's going on with you in front of whoever's in the room?
Mhm.
Um, but yes, their family unit, whatever that means, if it's a pet, um, children, friends, whoever that it is for them, that's their person or their significant other or their support, we absolutely want to include them in the discussions and in their plan of care because that's what's important to the patient.
Oh, absolutely. I love that aspect of it. That to me really speaks to that holistic care that we're talking about, being able to involve so many people into their care.
Mhm.
Now, what are the benefits of incorporating mindfulness and meditation practices?
Well, our brain is a very powerful thing. It's a
Yes.
very powerful organ. And it's kind of cliche, but mind over matter. So there's a lot of things if we're feeling anxious, um, if we're feeling uncomfortable, if we're feeling scared, if we can help the person be aware of what those triggers are and what can we do to help them, calm themselves. So, yeah, so mindfulness being educating them, continuing to speak to them,
Hmm.
even if they can't communicate back to you, I think is really important. Um, but also allowing patients their time to be with themselves. Sometimes they don't want someone hovering over them. They just need to be alone in their thoughts or just have some quiet time to
Hmm.
reflect. And so, yeah, I think that's very important, whatever meditation or mindfulness means to that person.
Right. And I think that this is just, I have not worked in hospice care or palliative care at all, other than, my background is ICU. And so
Hmm.
I've worked with a lot of people who have passed away,
Hmm.
but and we have transitioned our care sometimes to more of a palliative approach, but they were within, hours to a very short amount of days before they were
Right.
gonna pass. But it seems like, I would think from my own thoughts that anxiety is that high in the patients that you work with at this point?
Absolutely. I mean, everybody handles stress differently. Some
Mhm,
people are
mhm.
more emotional. Some people will. hold a lot of those feelings in. A lot of people are very open about, I'm, I'm feeling anxious, fear of the unknown. And part of what you have to do in hospice care, and I can't use it with men because men don't have babies, but if I'm talking to a patient that or a family member that has experienced pregnancy,
Mhm.
um, part of what we do need to do is educate these patients and families what's going to happen to their body.
Yeah.
What does this process look like? And the more that we educate and talk them through, this is what you can expect.
Mhm.
I think that that does help alleviate a lot of that anxiety. Um, because if you're constantly wondering, am I going to sleep all the time? Am I going to have pain all the time? Who's going to take care of my pet when I pass? So, kind of helping them work through all of those things that are causing them anxiety can
Mhm.
certainly help alleviate some of that. There are medications that we can use, but they're not a. It doesn't mean it's going to alleviate the problem. It may just
Right.
palliate it for a moment. And one of the beautiful things about hospice and palliative care that I love is having a whole team to support. So if I do have a patient that's experiencing a lot of anxiety or having a lot of problems, I will incorporate my social worker.
Mhm.
Right? The social worker is that's what they do. They can help them talk about coping mechanisms or talk through some of those fears. If some of that anxiety is caused from a spiritual aspect, I will incorporate our chaplain to kind of help them work through those things that are causing them anxiety. And I think that that is the wonderful thing about working with an interdisciplinary team. I can't be nurse, social worker,
Mhm.
chaplain.
Mhm.
Um, I love having a team that I can reach out to. And so when those anxiety levels get high, it's always helpful to figure out what is the cause of the anxiety. And then we can,
Mhm.
help make it better based on that.
And you have a whole team at your um in your hands basically to help you with
Hmm.
addressing, those emotional and psychological needs that that patient may experience because I know every journey is different
Yes.
for the patient and none of them are the same. When it comes to nutrition and dietary interventions, how do
Hmm.
you support the well-being of the patient through this palliative care or hospice?
So again, education.
Yeah.
Um, so probably the best example that I could use, and that I've used with my patients that I've cared for that have had a cancer diagnosis, let's say, um, if they have a tumor or whatever the cancer is that they're experiencing, um, if you eat 100 calories, the cancer is going to take probably 60 to 90 of those calories.
Mhm.
And so a lot of times they lose their appetite or they're starting to have trouble swallowing. So, what I try to do is, first of all, let them have whatever they want, whatever brings them joy.
Yeah.
Um, Tastes will change with treatment. So, maybe their favorite thing was ice cream, but now, due to medications that they're taking or chemotherapy or radiation, those taste buds have changed. And maybe now they like Brussels sprouts where they never ate those before.
Yeah.
Um, So I just try to talk to them and see, also educating the family that there are going to be times when their loved one's appetite is going to decrease.
Mhm.
We don't want to force them, but we can make small meals that are more meaningful or more robust. So giving them um, advice on maybe what to add. So they don't have to eat large meals. They can eat small meals and
Mhm.
get more calories in just those little bits, or little portions that they're taking. Culture can play a big role in nutrition.
Yeah.
And so, how am I going to know what their culture is except to ask? Um, what's important to you? What kind of foods do they eat? Um, maybe there's dietary restrictions based on whatever their cultural background is. So being in tune with that, but just consistently educating, especially towards the end of a person's life. Um, they may stop eating and
Mhm.
drinking because they're having swallowing issues. Um, and so when you go for at least 24 to 48 hours without any food, your body kind of goes into ketosis, which can actually can cause a sedating effect. And I
Mhm.
think, well, I know that that's our body's natural way of kind of protecting itself and making that process a little bit easier. But if I don't educate the family ahead of time that that could happen, it can create a lot of issues,
Right, a lot of
increased
fear.
anxiety, a
Yeah.
lot of fear. I'm letting my loved ones starve to death.
Mhm.
Um, you know, food is, we can't live without it. And so
Mhm.
just addressing those fears in a kind, and I can be very kind, but I have to be, I don't want to use the word direct, but I have to be very
Firm.
firm,
Yeah.
um, and truthful,
Mhm.
um, with them. And so that is the best way that those interventions can support them. I'm
Right.
also advocating, right? Because I've had patients tell me, my daughter keeps forcing me and I'm just not hungry, or I'm
Mhm.
feeling nauseous, or, the smell is making me sick to my stomach. So
Right.
I'll be the bad guy and tell daughter that, you know, I'll advocate for the patient if that's what they want.
Yeah.
And I'm okay with that.
Now, one of the things that I struggled with when my grandmother was, passing away was fluids. For
Mhm,
me, I wasn't as concerned about her eating, but there was just something that bothered me from a healthcare perspective. I don't know. I said, you can just leave her fluids going. Now, that was my only request was, can you just
mhm,
please just, leave her fluids going at a low rate. There was just something about it for me with dehydration.
mhm,
I don't know what it was. I'm not sure, but, um, I just had trouble with letting her dehydrate, I guess.
mhm.
Um,
That's a common fear. We experience that a lot.
yeah.
Um, and again, it all comes down to gently but firmly
Mhm.
educating the family member. Um, if we have patients on a tube feeding, th- there's going to come a time where they're no longer going to be able to absorb
Yeah.
that feeding, and it can actually cause them more discomfort,
Mhm.
diarrhea, vomiting, um, excessive swelling,
Yeah.
um, which then can impede their breathing.
Mhm.
Um, so that's with tube fed patients that are getting a feeding first that way. With IV fluids, the best way that I try to explain that is, um, there's a reason that they're not wanting to swallow. Either they're not feeling the thirst or the hunger that we would normally feel because their body is starting to shut down.
Yeah.
If we keep introducing fluids, as their organs start to fail, they're not going to be able to absorb them efficiently. And that's when you run into a lot of fluid, edema, that third
Mhm.
spacing, because their body just isn't able to absorb it. Then they start having that um, congestion
Yeah.
and the breathing difficulties. We can actually cause them more discomfort by introducing artificial nutrition or hydration than by just allowing the body to kind of take its
Mhm.
natural course, which again, we are concerned in an acute care setting about dehydration.
Yeah.
But when you're talking about someone who's getting towards the end of their life, as those organs start to shut down, dehydration again can be a very sedating effect, and it's the body's natural way of preparing them to transition.
Just hearing you, as you talk through this, it doesn't sound as scary
Mhm.
as what it did before,
Right.
before just, listening to you where you're like, "Hey, that's the body's protective mechanism. That's a way for it to not be as as hard on the patient and their body as they're transitioning. And so just hearing that just makes me feel more at ease myself now,
Mhm.
than I did, before. Um,
Right.
so I think that you are probably so amazing. I know just listening to you, you are amazing at educating not just the
Thank you.
patient, but the families and just
Mhm.
alleviating some of that stress and anxiety that they're feeling. Cause I know at the end of the day, it's how we still want to save our family member. We still want to make sure that they're taken care of. And so w- we look at it from a living perspective where we have to have food, we have to have water, we have to have all of these things.
Mhm.
And you're kind of knocking on our door saying, hey, that's what we need, but that's not what they need. Not right now.
Right, and, I try to validate families'
Hmm.
feelings, like, our natural human emotion is to be selfish, right? We don't
Right.
wanna lose
Yeah.
this person that we love, um, because that's a normal response,
Hmm.
um, but by continuing certain treatments or continuing certain interventions, we're gonna cause them more discomfort, and we don't wanna do that either, um, so I think a lot of times just validating, feelings, acknowledging the care that they're providing. Sometimes there's a lot of guilt there from the family.
Yeah.
You're doing all the best things, you're doing all the right things, and that this decision that you've made to forego treatment or to stop treatment is actually the most kind and loving thing that you could ever do. Um,
Right.
and this time that you've been given to spend with your loved one is a gift. Um,
Hmm.
if they had passed, in a traumatic or tragic way, we didn't get that opportunity or that time.
Right.
Um, and so now we have this time and it's a gift.
That's a really good way of looking at it. I'm
Mhm.
curious. When earlier you were talking about some knowing their background as far as their culture and their beliefs.
Mhm.
What have you run into, different cultures and beliefs that other healthcare professionals should be made aware of? Like, what are some of the things that you have seen?
Um, I mean, it can vary. When I worked in New York City, I worked with a hospice that had a very large Jewish population,
Yeah.
and there were there is a sect of Hasidic Jews that follow a very strict pathway when it comes to healthcare and
Hmm.
health decisions. Um, and so I have to ask questions or I'm not going to know. And I think that people appreciate that, especially when you're discussing what their culture is. Um, and so we would have to follow certain things before we could stop a treatment or
Right.
give a medication. I've had not very often, but I've had a few patients that were Buddhist. And as their loved one was, starting to transition and could no longer swallow safely or take in a lot of food, they would continue to feed them or continue to force feed them. Um, and here I am, I'm trying to educate about
Right.
the dangers of that. Um, So I had to ask, what is it about your faith or your religion? Why is this important? And basically, in their faith, Buddhists believe in reincarnation.
Mm.
And so if they don't feed this body, they won't be able to reincarnate
Oh.
safely into their new um, vessel.
So how do
Um,
you navigate that?
I just have to, I can educate, but
Yeah.
I have to meet them where they are on their journey.
Right.
And I have to be supportive of that, um, and put my own thoughts or feelings or beliefs to the
Right.
side because it's not about me.
Yeah.
It's about them. Um, and so, but I just continued to ask questions so that I could also educate myself. Um, it's kind of hard to watch because you know what's
Yeah.
going to happen, but at the same time, you have to be respectful. Um, Again, I'm a guest
Mhm.
in their home, and
Mhm.
so that's all I can do is be supportive and offer education and acknowledge.
Yeah. Have you seen any others?
Um, don't get very many Native Americans in hospice, but not so much during the caring process, but their death customs. Um, you know, they would have to be laid a certain way. Um, they would have to be cared for a certain way at the time of death.
Mhm.
Um, Muslim patients, their death customs were very significant. Um, you know, at some Jewish faiths, you have to open a window when they pass so that the spirit can pass on.
Yeah.
Um, they can only, in the Muslim faith, they want a imam to come and do their postmortem care. And so I wouldn't know those things if I didn't ask.
Right.
Um, and so it could be that maybe it has nothing to do with religion, but, you know, it could be just something culture within that family. And so I
Mhm.
always made sure that I asked, when your loved one passes, what is something that I need to know so that I can honor your wishes? I've had someone ask me as simple as, when the funeral home comes, please don't cover their face when you bring them out to the hearse. Um,
Yeah.
Let them feel the sunshine one last time.
Mm.
Um, so if I can honor that,
Right.
I'm gonna do it. But I think the biggest thing that I could say to any healthcare provider, you have to ask the questions. Talk to them, ask them those difficult questions, because they may feel like they're gonna, insult you, or,
Right.
or make you upset if they ask for a certain thing. So I just make sure to ask lots of questions
Well,
over time.
it's part of that holistic care where you're taking care
Hmm.
of them,
Right.
emotionally, mentally, spiritually,
Hmm.
physically. Um, so it should be taken into consideration when and we should be using a holistic approach to care for all of our patients. So
All of them. Hmm.
yeah, what are some challenges to implementing holistic approaches in palliative care, and how can we overcome those challenges?
I think the first thing would be, where's where's the care being provided, right?
Hmm.
If it's in an acute care hospital setting that doesn't have, maybe they don't have a spiritual care program. Um, they may have social workers, but they're more on a case management. So
Hmm.
they're just trying to do discharge planning, um, especially for the nurse. And I've worked in acute care. We don't have the time to
Resource and
sit
time
and hold
constraints.
hands. Yes,
Yeah.
time constraints. Um, and so if a patient is receiving palliative care, let's say from a home health agency
Hmm.
that has a palliative care component, um, again, they may not have all of the disciplines. So that barriers, you're seeing that nurse once a week, or maybe you're doing a telehealth visit with a healthcare provider for
Hmm.
30 minutes or an hour, just to address. So I think that some of those barriers are going to be availability. Um, can the hospital system or that home health, can they afford it? Do they have the funding to provide these services? Um, where you live could be a barrier, right? If you have to travel
Yeah.
50, 60 miles to go to a palliative care clinic, you may not have the financial means to do that,
Hmm.
or even the physical strength to make those trips. So there's also family that is a barrier. Um, a patient may want one thing, but the family is pushing them to do something else. And I'll be very frank, a lot of times it's not the patient
Great.
that is the issue, it's the family.
True.
That can be a huge barrier.
Right. Yeah, I can see the resource constraints, the time constraints,
Hmm.
the training, and the comfort level of the
Hmm.
staff that are, trying to take care of this patient. You mentioned,
Hmm.
like, the cultural beliefs, versus their own
Hmm.
personal beliefs. And then another thing that I picked up when you were talking is, fragmentation of care.
Hmm.
The care breakdown between, like, home and rural settings and metropolitan settings, lack of sharing what's happening, throughout the healthcare team, which,
Hmm.
fragments the care that the patient's receiving. Um, Earlier, you talked about, insurances, so looking at
Hmm.
reimbursement and policy limitations as well.
Right.
Um,
Absolutely.
yeah, and how do we overcome?
We have
That's a
to
lot to
continue.
overcome.
It is. We have to continue to educate, and we have to continue to um,
Advocate.
lobby our legislation to make changes in
Yeah.
reimbursement and the importance of palliative care and hospice in healthcare. Um,
Mhm.
and I think that that's the key to it.
Yeah.
Continued education, constantly learning and educating.
Yes, education, um, is a big one for healthcare professionals, but also for people who make laws and people who
Hmm.
run insurance companies.
Yes.
Money is another issue, which goes back to, the reimbursement issues and the
Hmm.
education. And so I see how it all plays into each other. But it has been, positive to see that the options for palliative care and hospice care have grown over time and that more people are starting to see the benefit of it, and starting to use it. So I think that's a positive.
It is absolutely a positive.
Yes. Well, Melissa, as we wrap up our conversation, is there anything that you want to emphasize or maybe that we just didn't get to discuss you want to make sure that we talk about?
I think the biggest message is that if you yourself or you have a loved one that's received a diagnosis, um, just don't get the education. You don't need a doctor's order to call a hospice or a palliative care and just ask for information. You're not
Hmm.
obligated. Um, but at least you can have that information to make an informed decision and know what options are available to you in the event that you want to stop treatment or your treatments are no longer effective. And that's the biggest. Don't be closed minded, just listen,
Yeah.
so that you can make the best decision possible.
Thank you so much. And I think it's important for us as healthcare professionals that you made a really big point today that there's a difference between palliative care and hospice care. And we need
Hmm.
to understand the difference and we need to understand what a holistic approach to care for the whole person and not just their symptoms, to address their physical, their emotional, spiritual, social needs, because you mentioned social a few times, to really
Yes,
support their quality of life during this really vulnerable moment for them. So,
absolutely.
when I think of holistic care, I think it builds trust. I think it honors all of our diverse values, and it helps patients really just to feel seen and heard, even during this vulnerable moment. And I think for me, and I know that I can sense it from you, I think that
Hmm.
brings a deeper meaning to our work. It reminds us why compassionate patient-centered care really does matter, even at the end of life.
It is a privilege to care for someone at the end of their life, and it has just as much meaning as bringing a new baby.
Yeah.
Um, it is an honor and a privilege to care for patients at the end of their life, for sure.
Oh, I think that you're amazing. Thank you so
Thank you.
much for sharing your
Thank you.
knowledge with me and our listeners. It was such a pleasure to learn from you. To our listeners, thank you for joining us, and I encourage you to explore many of the courses that we have available on elitelearning.com to help you continue to grow in your careers and earn CEs.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.